Thank you very much. So today I'm going to speak about how we use sensors for climate health adaptation in low resource settings and how we use AI to understand the data that we are generating. So in general, we are facing a climate health emergency where projections show that due to a warming world, we see that, for example, infectious diseases like malaria is expanding into territories that have not yet been conquered by malaria or where malaria previously has been successfully kind of gotten rid. But in general, what we see in also is that according to WHO, that about 500,000 people die per year, which are heat-related deaths. The most impact we see in low and middle income countries, so where people are faced with the highest exposure but the lowest adaptive capacity because simply they don't have the financial means to adapt. Especially in these settings, data gaps block targeted adaptation because we don't really understand what is happening in these populations and who are most vulnerable to which climate change impact. Just to give you a little bit of background, for example, to the mosquito, why this is related to climate change, particularly climate change impacts like high temperatures, flooding, droughts, create beneficial or preferential environments for mosquitoes to thrive. Especially if we look at different mosquitoes, you see that they have like temperatures where they thrive. So looking at the biting rate, for example, this lays around 33, 32 degrees Celsius. Also the mosquito development rate. So if we look at these kind of degrees Celsius and at climate change projections in combination with more preferential environments like flooding, droughts, high temperatures, we can see why malaria and dengue and other vector-borne diseases are on the rise because of climate change. So what do we do? Because things that you don't measure, you cannot understand. So essentially, this is the overview of the whole approach. So essentially, it's about understanding the climate and environment using different sensors. And because we are using more and more sensors to understand the climate and environment, we are faced with what do we do with the data? So how can we understand all of these data points that we have all of a sudden? This is where AI and machine learning comes to the help, which helps us understand patterns or kind of identify or explore patterns in the data that can be translated, for example, to dashboards or other outlets, and that hopefully then can inform adaptive action also for policymakers. Also, we are looking into how this data then can be made available to the community and how this can lead to engagement on the community level, and how we can feed back data that is also coming from the community, for example. So where are we doing this research? We are doing it currently in 3 sites. 2 are in Africa, so one is Burkina Faso, one Kenya, the other is located in Southeast Asia and Malaysia. We are doing this research in existing populations that are under surveillance. So in Burkina Faso, for example, it's a population of over 120,000 people that are regularly under surveillance. In Kenya, it's over 220,000, and in Malaysia, it's 40,000. It's a relatively new cohort. Especially with climate change, for understanding climate change needs at least 10 years of data. So better, the more data, and especially in low and middle income countries, we typically don't have these data sets. So this is why these cohorts, which are called health and demographic surveillance sites, are so important, because they have been collecting data regarding these populations, like who has died because of what, for decades, which we now retrospectively can also connect to climate data, and prospectively can also add other measurements. So what are we doing in these 3 study sites? So if we start from the left-hand side, we are working in these HDSS and these population health cohorts, and we are strengthening 2 types of data. So first of all, we are looking into how can we generate or understand better health data in these populations, and the other is climate data. So for the health, we are currently using individual sensors, which we give people to wear. Those are wearable devices. I will say in the next slide a little bit more about that. We continue to collect data cross-sectionally via interviews. So it's essentially that a household is at least visited once per year, and they're asked a specific set of questions, like who moved in, who moved out, did somebody give birth, did somebody die. And in addition, in the 3 countries, we are doing different health assessments, so climate-sensitive disease assessment to better understand the relation, especially between heat and diseases. For the climate-related data, we have built weather stations in all 3 study areas, because oftentimes the weather data that we have is not available for this location, and we have hyper-local weather. Like 10 kilometers from here, the weather is different than to here. So it's really important understanding what people are exposed to. This is why we have put, at the moment, it's 5 weather stations per study geographical area, and we are currently working on building up more. We are also using remote sensing, and Max is going to present on that in a later presentation. And also we put indoor sensors in the homes of people to understand how hot it actually is in their homes, and also the humidity level. So we generate a lot of new data on the individual health of people, and we generate a lot of data on the environment. So what do we do with the data? Currently, we are moving that data and are connecting it in a thing called a graph database. So a graph database is a new approach on how you can store data. It's not a relational database. It's much more dynamic in a way that it kind of allows you to connect data, even if it comes in different granularity. So for example, with the wearable devices, we get measurements like almost every 15 seconds. The questionnaire is done once a year, so we have like different granularity of data, and oftentimes this is like super difficult to connect. But the graph database allows us to connect this data like you would draw it on a blackboard, for example, so you can connect the data with individuals, for example, and having all of this data in like one database then allows us to use artificial intelligence to discover risk clusters in the database. And hopefully, or very likely, this will then guide us to better interventions, because we better understand how risk clusters in the population and what or basically like which groups to address, and of course also for better financial support from the governments. We are currently using the Garmin Vivosmart 5, so this is a commercial device which measures heart rate, steps, and sleep, so how much people sleep each night, sleep quality, how much people move around, and the heart rate. And this is already a lot of data that can give us insights into the health of people. Why are we using commercial devices? Because we want to do this on the population level. So we want ideally as much people as possible to wear such a device. And in low and middle income countries, people don't have the means to buy a device themselves. So we are essentially providing it to individuals as part of the project funding. The Garmin also allows access to the raw data. So this is like one of the only manufacturers who does that. The other manufacturers only give pre-digested data after they've run their algorithms. We also just to give you a visual kind of input, so this is the weather stations we have installed. So on the left-hand side, you can see one of the state-of-the-art weather stations that we have built up in Kenya. So typically you need a 3 by 3 meter land to put a weather station. And maybe just for you to ask yourself how much would this cost, or how much you think you would want to pay for such a weather station. So one weather station is around like $15,000 US. I guess this is about 30,000 New Zealand dollars, I guess. So you can see it's also a bit tricky in financially upscaling such weather stations. And this is why currently in Malaysia, we are piloting 3D printed weather stations. We have already built now 3. And you can see one on, this is the very right-hand side picture, sorry. So this is a 3D printed weather station. So all the bits and pieces that you can see in white are 3D printed. And here you can see the 3D printer. So it's a very small device, maybe double the size of a microwave. And a 3D printer like this costs around like 3,000 New Zealand dollars. And just because I told you this is about like 30,000 New Zealand dollars, so how much do you think this is, the 3D printed weather station in comparison? So this is around a little less than 2,000 New Zealand dollars. Okay. So you can see that in terms of financial investments, it's much lower, and it also allows us to, or people in Malaysia, for example, to 3D print like components when they break down or when they fall. Because, for example, these weather stations we have imported from Germany. So if anything breaks, or if after 10 or 15 years anything breaks, it's questionable if things can continue to run. Just a little bit more on the graph database, since this is a session on AI. So a graph database structures data as nodes and edges. So nodes, for example, you can imagine like a person, maybe yourself, who has the relationship daughter or son to your mother. So the edge would be this relationship of daughter or son. And you can easily kind of draw relationships between things. So not just what they are, but essentially how things are related to each other. And this is how you basically build up the graph database. So you're kind of encoding the complexity in these simple annotations. So it's nodes and edges. So essentially each entity, like for example a person, a house, a weather event, becomes a node, and then you annotate the relationship as an edge. So for example, a person lives in this house, a person is exposed to this weather event. So this is basically like on a simple scale how you would build up the graph database. And this allows you to build up really complex queries as well. So for example, you could ask questions like, find all individuals living in low ventilation homes exposed to 3+ consecutive days of over 38 degrees Celsius, who report sleep disruption and take diuretics. So you can see that, you know, by building simply up such a graph database with relations like nodes and edges, you can query very complex questions in the database, and it gives you direct answers. Essentially, the idea of the graph database is also allowing us to uncover hidden connections, because typically in science we first ask the question. So like a research question typically reflects what we know of the world. And then we try to find out, is it true or not? But the graph database, since we have so much data, we're basically coming from the other end. So we are kind of exploring or, uncover hidden connections. So it basically gives us like clusters that we then see basically what does this mean in the real world. So we don't come with the question. We start basically from the other end and see what does these clusters actually tell us that the AI algorithms can or have identified. So we don't come with like a predefined group structure. We, kind of explore the data from the other end. Essentially, what you can do with that as well, for example, it allows you to understand centrality. So, for example, you can understand who is most connected to a high-risk node, so a person who is frequently exposed, for example, to multiple vulnerable household member or hotspots. You can also do a link prediction. So, for example, you can estimate the likelihood of future illness or events based on emerging patterns in the network. So as I said, unlike traditional hypothesis-driven models, graph-based AI enables an explorative approach. So it basically helps uncovering unexpected risk pathways and complex interactions that may not have been hypothesized in advance. Just to give you an example, so this is also a very nice feature of the graph database. It allows you to visually represent components of the data. So this is just a visual representation of our actual data set from Burkina Faso, which you can see here. And what you can see is who is exposed to what conditions, where and when. It can help us identify clusters of vulnerability. So for example, acid poor, high migration, recent death, but also very complex questions like I've shown before, and can help us really to target interventions from zoonosis control to housing upgrades. It can help us to build AI models for early warning and resource allocation. So here, for example, but it's a little bit difficult because the resolution is not so great, but here you can see also weather events, which we can link up. So we can, for example, annotate tropical nights, and we then can identify people who have been exposed to tropical nights more than 5 days, because exposure to heat is not like, you're once exposed and then all of a sudden you have a disease. It's like a cumulative process. So there's like, requires a certain amount of exposure. So it's not clear cut. So this is why it's important to also have these accumulations in the data set, which is also possible to reflect in the graph database. In malaria, we have built up a data set where we had a study population of 300 people, which we followed for around 3 months. I think it was in total in the end, where we did like every 3 weeks a malaria test to understand who had malaria. And this was basically our training data set. Here you can see some images from the study site and the malaria rapid tests in Kenya. This is also a picture from the lab. Basically, we had the people wear throughout these 3 months the wearable device, so this Garmin Vivosmart. And because we have so much data about each individual, we are able to set individual thresholds. So this is what you can see here. So we are also able then to see and define healthy ranges and unhealthy ranges. So when people are out of a healthy range and are within a healthy range, which allows us to basically send them messages early on. So this is basically the basis of the early warning system. And here you can see from another study, so the challenge means in this study, people were basically infected with malaria, and this is the challenge. So you can see here the challenge means they've been infected with malaria. And then in this candidate, you can see that the heart rate deviated before malaria was found in the blood. So heart rate is really a helpful indicator to use as an early warning predictor for malaria. Work is, as you can imagine, because we are collecting a lot of data about individuals, we also have a lot of missing data. So here you can see on the right-hand side, this is the data set that we generated in Kenya, and the white dots are missingness in individuals. So you can see there's quite a lot of missingness, and the question was how to deal with that. And essentially, we found that we had more than 50% data loss because of different reasons. And what we did was to develop a generative adversarial network to basically fill up the missing heart rate data that we had. So this was combined with a rule-based anomaly detection. So this was a finite state machine to flag early infection signals. We used another data set, a COVID-19 data set, to basically cross-train the filling up of the missing data because COVID-19 shares similarities in the pathology of malaria. And what we found was that it works quite well. So we really can train machine learning models across different diseases. Essentially, to summarize, so, to give you an overview of what we've done. So essentially, in this Kenya study, we continuously collected wearable data with 300 participants. Infection events were validated by PCR and clinical diagnosis of malaria, and then basically trained a generative adversarial network on another COVID-19 data set to fill up the missingness that we found in the heart rate data that we had with the wearable devices. Then reconstructed reconstructed heart rate data was then fed into a finite state machine, which then basically compares the different baseline heart rate. So overall, we found that in addition, so this imputation, so this filling up of data allowed us to have 42 additional early alerts, which would have not been visible with the raw missingness data, essentially. So overall, basically, we were able with this malaria prediction to predict malaria 11.9 days before actual symptoms, and basically showing that the system was able to detect physiological shifts coinciding with parasite replication and not just at random noise. So another example case from Burkina Faso, where we looked at chronic obstructive pulmonary disease, which is also adversely impacted through heat. So essentially, just to move a little bit faster, what we've done, just to give you the idea, was that we collected data in the population with the spirometry and a questionnaire. So there's a standardized questionnaire to find out the likelihood of you having COPD, so chronic obstructive pulmonary disease. And we had study participants also wear the wearable, essentially, and we did this in 2 different groups. Then 1 year follow-up with 100 participants with the COPD and 100 participants with no COPD. So this is the study, and we have field workers come and visit the study participants every 2 to 4 weeks. And what we did in addition to that was that when the field worker comes to the homes of people, that with the tablet they record the breathing sound. So it's basically just putting tablet next to the mouth of the study participant just to record the breathing sound. And other studies also have shown, so we do this like for a minute more or less for each study participant, and the idea is that we then later based on the questionnaire data, because we know if a person has COPD or not, because we also did the spirometry measurement to learn a machine learning model that can identify COPD simply by the breathing sounds of a person. Other studies have done this or have shown that this works, mostly in high-income countries, and we are doing this now in Burkina Faso, so this is work in progress, which I wanted to give you as a use case. Another thing that we are going to take up in the future, so this is a future basically way for us moving forward, since we are working with these data sources already. So this is research done by Google, and they have used data sources similar to what I've presented you. So they are using also wearable sensors, questionnaires, data from the health system, but also other inputs, for example, like images, text, time series data. So this is very similar to the data that I've presented you, essentially what we are generating as part of our studies in Kenya, Burkina Faso, and Malaysia, where we have the wearable data, we have the time series data, which is the climate data. Potentially we could also add the satellite-based data in the future. And essentially this trains a specific health large language model, which then is able to do certain tasks. So you can ask it different questions, also predictive questions. And Google, you can look up the paper, it's really interesting. So they are able then, these trained health large language models, to predict certain healthcare activities, for example, like mental health, cardiovascular health, but also activity. These large language models, for example, they've been cross-trained through other data sets which are publicly available. So, for example, Live Snaps, the second data set contains data about sleep, and then the Mimic 3 data set contains data on cardiovascular health. So you can use publicly available data sets also for training these large language models. And essentially how they did it is that they questions just like ChatGPT. So you can ask, okay, if this is my data, what will my readiness level be, for example, with regards to mood, or what will my sleep quality level be given this data in the next few days. So you can basically use also large language models to help us with this prediction task of asking or understanding what health impact may come out of this individual in the future. Here's just the last slide. So how can this be helpful for climate adaptation use? So for example, it could be helpful for early heat stress detection. So you could combine wearable data with weather data to detect heat strain. So for example, farmers could receive alerts to rest or rehydrate. Also for vector-borne diseases, so you could integrate climate with physiological data to detect infection patterns, what we have done now differently with other algorithms. We will also try in the future and compare with large language models. Behavioral adaptation coaching, so you could used a large language model to suggest safe working or sleep schedules based on forecasted heat humidity. So for example, tomorrow's wet bulb globe temperature exceeds safe limit, adjust field work hours. Or it could be helpful to building policy dashboards where you have aggregated anonymized data shown community level heat stress or infection trends, which could then help health ministries adapt resource allocation in real time, for example. Thank you. Okay.
Yeah, thank you very much, Mrs. Barteit. I think we will leave it with 2 questions from the audience, if that's possible.
Just a second.
Hello, that's very exciting. That looks really interesting. Where would you like to take this? Like, in your kind of mind, the ambition for where you think this can go, and where are you seeing some kind of cautions and risks, the approach overall?
Yeah, okay. This is like a question which can fill many days of conferences, but thank you very much. So in general, we are doing this work now with looking at heat as an exposure, but in general, I see this very much fitting into precision public health, where we move from general health, like for example, if you think about drugs, they are not individualized. I mean, basically, we all take the same amount of content. So if we take ibuprofen, most of us take 400 milligrams, but it's not individualized to your own metabolism or to you as an individual. So I see this very much helping us to move forward in terms of individualized health, so precision public health. So certainly wearables can be one component that can certainly help us understand and then also feedback to the healthcare sector, for example, to your physician on an individual level, so for better individualized health in the future. So I see this is where this is going very much. And for example, wearable devices can also become, and I think especially the Apple Watch is showing this, because it gives you warnings. It records your measurements, and it can do so in a very precise manner. So it can very much help us also move from kind of reactive healthcare, where we only go see a doctor once we already feel bad or have symptoms, to like, prevention. So not waiting until the disease has broken out, but, preventive. So when you see first indicators as soon as possible, then you go see a physician and intervene at a much earlier stage, which hopefully will allow us to reduce the burden of disease and also, increase overall life quality. The concerns are purely, I think, ethical. I mean, there's like a whole body of research looking into ethics. Honestly, I'm not doing that so much, but certainly in terms of people benefiting of this, of course, there's always concerns, like where you think of governments which may use this information to identify individuals not complying with what they want. The same as like insurance companies or others who may benefit from this financially in some sort. So I think it requires, quite some regulations to prevent kind of misusage of this data in the sense that it is meant to be, because I think overall it can help us achieve a higher quality of life, with less suffering. But as always, we need to think how we avoid getting this information in the wrong hands. Yeah.
Are there more questions from the audience? Yes, one more.
So this is really, really cool. And I was particularly impressed with the malaria, where you were able to get an alert just based on the heart rate data from the wearable, like 12 days before.
Yes.
And so, we've done work looking at, in New Zealand, we did a lot of work with COVID and a lot of work using wastewater data to try to use that as like a leading indicator of infections, but that's all at a population level. There's a whole bunch of issues with it. So is this specific to malaria? Do you think it could be applied to a whole bunch of other diseases? Is there any limitations to that, or could we do it for everything?
So currently we are doing it for malaria, and we are looking into upscaling. So this is the data set that we had on 300 study participants. But for example, in the future we will also look into dengue, which has like similar pathologies as malaria, and we will also need the most important part, of course, going beyond the prediction is the connection to policy, NGOs, and making this information relevant for the people who need this information. So, yeah.
Thank you very much for your response.